Hello, and thank you for joining us for the Health Professional's Guide to Screening, Brief Intervention, and Treatment. This is part one of a three-part series that we'll be offering in the month of September. The first part is focused on screening patients and using a variety of validated tools that will focus on alcohol, drug use, tobacco, and prescription drug misuse. So welcome, everyone. I'm Tracy McPherson. I am at the University of Chicago NORC. I'm a senior research scientist there, and I co-lead the big SBIRT initiative with Dr. Eric Goff-LaRue. Feel free at any point following this session to email me if you don't have an opportunity to ask questions or would like more information about these tools. I'd be glad to assist you in talking to you about how to actually put the use of these tools into practical implementation in your site. Also today we have Lee Fisher, who will be presenting with me, and she will be joining us when we get to the point of talking about a very specific tool called the Assist. And there's Lee's contact information, and I'm sure she'd be glad to entertain questions for you as well. This webinar is just a small portion of a wonderful new training program that we have launched with many collaborators. The guide is called the Health Professional's Guide to Screening, Brief Intervention, and Treatment. And many of you are participating in the big initiative Hospital SBIRT and will recognize some of these collaborators that are working with us and helping us to move screening, brief intervention, and referral to treatment into routine practice across hospital systems. All of these different collaborators have significantly contributed to the content of the Health Professional's Guide, as well as to the webinar series and all of the information that will be contained in them. By the end of this particular training, part one, we envision and really hope that you'll be able to feel more comfortable in screening patients for unhealthy alcohol use and drug use using brief, valid questionnaires such as the AUDIT-C and the AUDIT, the CRAFFT tool, the DAST, the Assist, and the single item screeners. Following the webinar, we will have an opportunity to open it up for questions and answer session with both myself and Lee, and we'll be sending you a link to participate in an online, very brief evaluation of the webinar that you participated in today. And your feedback is very important to us, and it will continue to help us to improve the quality of the training that we offer you in the future. And so if you could take a quick moment to complete that, it would be greatly appreciated. And another housekeeping, just to let you know, we are recording this session, and we will record all of the sessions in the three-part series to make it available to others in the future. You might want to refer your colleagues that you're working with in your hospitals to take advantage of the archived version. It'll be offered for free. It'll be available 24 hours from our website, and I will show you a link at the end to our website where you can get more information about a full range of webinars that will be, we have already begun to offer in September, and some that are scheduled. So let's first start, but I know we all recognize that unhealthy drinking is a public health and safety issue, and whether you're working doing direct care or indirect care, we've all seen the consequences of unhealthy drinking and heard the stories. And we know that the public health impact is significant. And SBIRT is one of those promising evidence-based practices that we hope will contribute in some small, yet we hope in a very significant way, to improving the lives of people, of our patients, of our families, and improve safety for the public, for our workplaces, for our roads. And so we're hoping that this three-part series will help you at an introductory level begin to take some first steps by implementing routine screening and the use of validated tools so that we can do early identification and hopefully prevent those negative public health outcomes and the safety concerns that we all see. So we know that alcohol usage in the U.S. is significant, although the majority of Americans who do drink do so without negative consequences. Many of the settings that we're working in, we see that proportion of the population who is engaging in drinking that leads to negative outcomes and risks associated with physical, emotional, legal, financial, family, and work problems. So it's something we see a lot in the work that we do. You may be familiar with the 4 patterns of alcohol use in what is often referred to as the drinker's pyramid. Now, although we're used to seeing it, and we see a very significant proportion of the population among our patients who have these negative consequences, it's important to sort of keep in mind and perspective when you look at across the general population how people fall into different risk categories and what proportion of the population is really the target of SBIRT in terms of reducing risk and reducing negative outcomes, the safety issues, and so forth. And the drinker's pyramid is divided up to give you a visual representation of where people fall along the risk continuum. So the patients that we see who are not at risk, that represents about 40% of the population. And then about 35% of the general population is at low risk. And so these are the folks who generally, who do, among those who do drink alcohol, are not engaged in risky behaviors, or not drinking above the safe low-risk guidelines. And the low-risk guidelines are provided to you on the right to help you understand more about what it means to be low risk, or what it means to be in the moderate risk category or high risk category. So the moderate risk category, the 20% of the population, and the high risk, the 25%, these groups of individuals are those who are exceeding the recommended low-risk guidelines. So the low-risk guidelines for men and women and older adults are different. So let's look at what those guidelines are. For men under the age of 65, the guideline is no more than 2 drinks per day, 14 drinks per week, and 5 drinks per occasion. And for women and men over the age of 65, it's no more than 1 drink per day, 7 drinks per week, and 4 drinks per occasion. And so these are the guidelines that we're using, and we'll be talking about the use of screening tools that will capture consumption that is above or below these guidelines, and we'll show you some tools, as well as tools that will not only look at level of risk, but also the consequences that an individual may be experiencing. And for these different risk categories, we can give you a little bit more information about what it means to either exceed one or more of these risks that puts them in that category. So we talked about no risk. So obviously those are people who never drink alcohol at all. The low risk, they never exceed those recommended guidelines that I just talked about. they never exceed the daily, the weekly, or the per occasion limits. The moderate risk, those are the individuals who regularly exceed one of those limits. So either recommended daily limits, weekly limits, or the occasion limits. So they exceed one of those. And the high-risk group are those who regularly exceed two or more of those recommended daily, weekly, or per occasion limits. So this gives us a sense of the proportion of the population that would receive a brief intervention. So with SBIRT, we know that we screen routinely, we figure out the level of risk, and then some proportion of individuals are going to get a very low level of intervention, and others, as you move up the risk continuum, the brief intervention becomes more intensive. And so in part 2, we're going to talk about how do you use the screening tools and the information gleaned from them to determine the level of risk, and then what will be the brief intervention, what goes into the brief intervention at each of these levels of risk. So I hope you'll join us for part 2 to learn more about that. In part 1, we're going to talk about the tools that help us determine where people are on this risk continuum. We know that the costs associated with alcohol problems are astounding. The newest estimates being $223.5 billion annually. Those estimates are out of Center for Disease Control. And the misuse of alcohol is linked to almost 50% of all trauma, injury visits to the ER, which drives up employer health insurance costs and employees' premiums. So we have a lot of opportunity to identify the millions of people who are in that risk range. I think it's about 32.5 million people. And we have the opportunity to employ routine screening in hopes that we can drive down these costs, and also we can reduce the ER visits, the trauma visits, and so forth. It would be a nice, I hear often that they see that individuals in emergency rooms and in other settings see patients come through like a revolving door. They have multiple alcohol-related ED visits, and it would be the use of screening and brief intervention has real promise in being able to reduce those visits and those associated costs. And I hope that this series will help you begin to implement if you're not currently implementing, and also to begin to look at in your own hospitals and in your own medical settings what the costs are, what are the implications, and evaluating whether screening and brief intervention, when you implement it routinely, is making a difference on those costs and those other health and economic outcomes. And certainly we have, as part of the Hospital SBIRT Initiative and our training and technical assistance activities that we'll be doing this month, we have the opportunity to provide you with some information about how do you evaluate outcomes when you implement routine screening and brief intervention. And so we would be glad to talk to you more about how do you look at those in your own setting, and then also how to help make the business case within your setting about why it's important to pay attention to it by looking at your own data and helping you look at your own data to make that case. So we hope that you will reach out to us for assistance with those things as well. Now, the skills for health professionals, a variety of healthcare settings, a variety of hospital settings, medical settings are really ideally suited for intervention to prevent the third preventable cause of death, unhealthy and dependent alcohol use. Ironically, few practitioners use simple, fast, and inexpensive, effective early intervention programs, and few routinely screen using very brief, validated questionnaires that can be integrated seamlessly into existing practice. And so I hope that you'll find tools today that you'll see that may meet your needs, and that you'll begin to implement them and integrate them in what you're currently currently doing. And it may mean that you're adding something to what you're currently doing, adding a screening tool that you weren't familiar with, or it may be that you'll find that you want to replace the screening tool that you're currently using with an alternative tool because it may fit with your setting better. So who can perform screening and brief intervention and referral to treatment? And I think whether we're talking just about screening or the other pieces of SBIRT, it's any trained health professional, paraprofessionals, all the way up to a variety of levels of expertise on a continuum of expertise. And I think what we see is that really the keys to success is that use of the non-judgmental tone in delivering screening and that non-judgmental listening and the ability to guide patients to make the connection between alcohol and drug use and their health and injury and illness, making the connection between how they score on a screening and how that's connected, why they might be in there seeking health care services, or it may be connected to other things that they're talking about around family concerns and so forth. And it's about the skills to make those connections and be compassionate and non-judgmental. What can health professionals do? Well, we would ideally love to see screening brief intervention implemented routinely as a standard practice with all patients as appropriate who come through a given medical setting. And but there are also, it might be that you're beginning to implement this in your setting and you're looking for the windows of opportunity. What are they? And identifying where screening makes sense in those windows of opportunity and seizing the teachable moments. And so positioning screening at the right place and positioning brief intervention at the right place is very important to the success of making this routine practice and a sustainable practice. And so it's something you might have to reflect on with your team. Take the information about the tools we'll talk about back to your team and talk about where do these fit. You know, there are different brevity. They can be delivered in different formats. There are a lot of different considerations. And so how do they, with how they're administered and how long they take, how does that fit within that window of opportunity that you've identified in an ED versus an inpatient setting? Those are really important things to when you're selecting a tool. So unhealthy alcohol use can be effectively managed and addressed in a variety of healthcare settings if the drinking pattern is identified. So we have to identify the level of risk. And really the biggest obstacle to effective screening is really a failure to ask. And that's what, if we can make it easy enough for practitioners to ask and find the right folks in those settings to ask, that's really what it's about. That's the biggest hurdle so far. We find patients will answer. We just need to ask and find the right moments to ask. So as you can see, we're talking about introducing SBIRT as a part of this series, and this first series being on screening. But to give you a high-level view of what we're going to be talking about in this three-part series, we're going to look at all three pieces of SBIRT. So screening, brief intervention, referral to treatment, and follow-up. When we talk about screening and brief intervention, we're going to assume when we talk in all of the three parts that this is the basic underpinning or workflow that you would see in a medical setting. So that we're all on the same page of how we're conceptualizing it, we're picturing that at some point a patient arrives in a healthcare setting and they engage in initial contact. Some basic information is gathered from this patient and a brief universal screen is provided. And this may be a very brief screener, what we may call a pre-screener to a screener. It could be a single item, it could be a two-item, something very brief. There are settings in which don't use the pre-screeners. They just move straight into a full screener. But we'll assume that you have that option in many medical settings. And this will give you a sense, too, to start entertaining, well, what would I use in that initial contact versus as you flow through that process where you did a pre-screen and you determined that there was some level of alcohol, tobacco, or other drug use, and then you administered the full screen. For example, here we give the example of the audit or the DAST. If during the initial contact the individual doesn't pre-screen at risk, then we would assume there's no ATOD use risk, and then the right level of intervention will be applied, and we'll talk more about those level of interventions in Part 2. But essentially here you have the opportunity to think about how do we use one tool, two tools, multiple tools in different parts of our organization, and selecting the tool that makes sense for that initial contact and context and who's delivering it. And then from that full screening process, we'll be able to determine with the different tools that level of risk, and then the level of brief intervention, the appropriateness of referral, and so forth, and continuing the process on to follow-up, which we'll be talking more about in Part 3. So screening. The process of screening is the process of assessing risk. And the tools that we're going to talk about today, many of them are very, very brief, under 5 minutes, some 30 seconds. Some may be a little more if you're delivering them in a conversational style. But they're standardized, they're validated. Many of them look at quantity and frequency and consequences of use. Many of them have been administered in a variety of formats. Some have been validated using verbal, computer, paper, and pencil. Others are a little earlier in the research around delivering them, telephonically. But certainly there are plenty of tools to choose from that have a variety of administration modalities that have been validated. And then asking about alcohol and drug use may be actually harder for you than the patient. So regardless of which tool you're going to choose, it really, what we find is that it can be the practitioner's uncomfortability with delivering the screening and asking the screening questions that sort of gets in the way. We find that more often than not, very few people refuse or react negatively to being asked. And so what we would encourage your teams to do is to practice the screening, whether you have a clinical supervision or you can do it on your own. Just hearing yourself say the words and get comfortable with it is really the first step in being able to really do it successfully in your practice setting. And many people aren't going to present for alcohol or drug use, and so we have to keep in context here that people are going to be presenting for a variety of other concerns, and we have to be sensitive in how we weave in the screening to address, and if we can, make the connection between their presenting problem. And sometimes that really does take some practice, and how do you weave it in, and how do you begin the conversation. And we have a little bit of guidance to offer you on how to begin that conversation around screening. And keep in mind that, in different hospital settings and other settings where SBIRT is used, that different people do different pieces. Some may provide the screening, some may provide the brief intervention. In fact, within the screening component, some may have one person do the pre-screen and someone follow with the full screen, and then someone else then do the brief intervention. So there are many people that may be involved, and certainly that's an acceptable approach. I think the key is implementing it as seamlessly into your existing operations as possible to avoid disruption in flow during those triage and screening processes of which the patient goes through their services. And brief intervention, which we'll talk more about in Part 2, is really looking at behavior change strategies. So we'll be talking about how do you help the patient reduce or stop unhealthy drinking, how to provide feedback on alcohol use risk based on the screening for, how to provide normative feedback to others about how their consumption compares to others, and we'll learn about the consumption through administering the screening tools, how to offer simple advice, pros and cons of drinking, exercises, exploring those with the patient, and talking about how to engage them in a conversation about change. So that will be coming up in part 2 on September the 25th, and we'll be talking about a range of protocols that are very brief, in 30 seconds, congratulatory feedback that really matches well with someone who screens at low risk or no risk. And we'll be talking about brief interventions that are more expansive. They may be 5 to 15 minutes, and that may be designed really as a function of the elements that go into the brief intervention and the extent to which you're using motivational interviewing strategies to have a conversation about risk, and tying that to the screening results. And so we'll be talking a lot more in depth, and we'll be showing you protocols that implement the screening tool and the brief intervention, and provide some scripting about how to deliver and introduce the screening, and then how to introduce the brief intervention. And then in part 3, which is September 27th, we'll be talking about referral to treatment and follow-up, and talking about how engaging the patient in discussing options for referral to treatment, a menu of options, looking at our referral sources, engaging them and doing a warm handoff if possible to connect them with another medical specialist, a treatment provider, addiction treatment program. We'll be talking about different options there, medication-assisted treatment also being one of them, and what are resources and how do you learn about how to connect people to that. And then follow-up, how do you engage patients in follow-up and care management. So if someone is screening at high risk and we refer them to treatment, there are some really nice ways of continuing that care management process, and we have some tools that can help with the handoff, the warm handoff to someone, rather than just giving them a piece of paper and sending them on the way. But really starting from the screening process all through the referral and the follow-up, a continuous process of working with patients who early on you identify as screening at high risk. And so that will be part of the part 3 session. So we have a number of webinars coming up. We'll talk more about this, so I'm not going to go into it for this introductory series. But there are a number of publications out there. We have many links to the clinical case and the business case, and we have webinars on those topics to help you get a better grounding in what is the evidence around screening and brief intervention, and what are the organizations, the government agencies, and so forth who recommend it as standard practice. And so we have lots of resources on our hospital Big Initiative website that can speak to that. And we're also offering, as part of the training and technical assistance that we're doing now, is to talk with organizations about how to build the business case and the clinical case, and how for you to become more equipped to share that information within your own organization. So I hope if you're trying to have those conversations with your leadership, that you'll take a look at our website and attend our webinars, and feel free to circle back with us if to help you be able to craft those messages. We hope that you'll take full advantage of those opportunities. And this might be just one way of summing up some of the literature at a high view. When you look at the evidence for screening and brief intervention, when you look at the different substances, alcohol misuse and abuse, illicit drug use, misuse and abuse, and tobacco use, the evidence is pretty comprehensive and overwhelming across the board for screening, brief intervention, and referral to treatment for alcohol use. what we can say is that for illicit drug misuse and abuse, that it's growing, it's inconsistent, and there are large demonstration projects going on that are funded by NIH that show that brief intervention is promising. So we are certainly eager to hear more, and then in the tobacco area, I'd say we are even further along in the evidence base, and like alcohol, pretty much across the board, there's evidence for the effectiveness for a brief approach that's consistent with SBIRT. So we hope that you can even use this information right here to help communicate with your staff and your leadership around the case for doing routine screening and brief intervention or referral to treatment in your setting. So you may find that some of this is a bit of a refresher. You may discover new tools that you have never heard about, or you may have heard many mixed messages about different screening tools that are out there, and not really understand why in your organization. For example, you have the cage in there, you're not sure how it was selected or what it's really trying to measure, and we hope we're going to provide some clarity for what the tools do and don't do and the advantages of each. And regardless of your level of skill, again, anyone can do this if trained. The important first step is the same. It's really about asking and being comfortable with asking, and then everything really flows from simply asking sensitive questions in that non-judgmental, compassionate way. So part one, screening. Let's dive into the critical components of screening. First, you have to ask. I think I've drilled that in enough. We have to ask. We have to be comfortable with doing that. And we need to be respectful, and that really does go along the lines of thinking about our tone and that judgmental, non-judgmental approach, and being respectful that, you know, they have the opportunity to answer or not answer, engage us in a conversation or not engage us in a conversation, and just trying to be present and thoughtful and non-judgmental in the moment of screening is a very respectful way, because we know that we're asking them lots and lots of questions about all sorts of things, and so it's just a good rule of thumb when you're asking patients anything. So it's very similar. Screening is around alcohol use is no different. Getting your patients to give you permission to discuss alcohol or drug use is, again, another very respectful thing to do. And so what we often suggest is that we ask permission to ask them questions, to ask them the items that are on the screening tool. And most people say yes. Most people will answer those questions, will give us permission to move on. And then the other key is really to avoid arguing or being confrontational. Often I get the question about underreporting, and in some cases underreporting may be a concern, and in other settings we find that patients are very forthcoming with their alcohol and drug use behavior. And you know, if they are underreporting, or they're, you may doubt that they're being honest with you, the approach is really to avoid getting caught up in that, or there's something fearful or resistant about what's going on with them. And so not getting caught up or being confrontational or forcing it on them, and just sort of staying neutral and non-judgmental. Again, we think that those are real keys for success in delivering any of these screening tools. So when you raise the question about alcohol use, I think it often may be more how we do it, how we say it, and our tone sometimes, and even the precise words that we use. But what we want to offer you is a way to do that in that non-confrontational way, respectful way. And so this may be during a clinical intake, some sort of verbal interview. This could, you may do work on the phone. These are all examples of what you could use in a variety of those modalities of administration. But you can introduce the topic by simply saying, you know, I'd like to ask you several questions about your alcohol use. I ask all of my patients these questions because sometimes alcohol plays a role in the situations that lead patients to seek health care services. Sometimes alcohol becomes or is the problem. May I start? just a very neutral way of letting the patient know that this is something that you do with everyone. Regardless of what screening tool you choose, you can introduce all of them in this way. If your patient questions asking you about alcohol use, you could simply respond with something like, I ask everyone about their alcohol use. It really helps you better understand your health and the ways to promote wellness and prevent health and other problems. Would you mind if I continued? Generally, the patient does consent, and then you might follow with, now I'm going to ask you some questions about your alcoholic beverages, use of alcoholic beverages during the past year. May I begin? Again, very neutral, very simple, very direct, very straightforward, and this is shown to have some success with people responding. So we talked about in the sample workflow that there is an opportunity to do a pre-screen, a 1 or 2 item screen that can help us determine whether we want to administer a full screening. We wouldn't want to administer a full screening to a large number of patients who really don't, it's not warranted for, because what that really does translate into is time, staff time, and flow, and a waste of resources where you could be focusing those in your SBIRT program someplace else. And so a really a nice way of doing that is by just integrating into your pre-screening process the simple question of, do you sometimes drink beer, wine, or other alcoholic beverages? And we know from the drinker's pyramid at the 40% at the bottom never drink alcohol. So this would screen out 40% that would no longer have to be administered a fuller screening where it would be inappropriate. If they said yes, we would want to administer a fuller screening. We could move on to the AUDIT-C, which we'll talk about, or the full audit. Here's another pre-screening question that you could consider, which really looks at not just alcohol, but alcohol, tobacco, and other drugs. So in the past year, how many times have you used the following? Alcohol, more than 4 or 5 drinks in a day. That's for women and men. So you would say, in the past year, how many times have you used the following? Alcohol, 4 or more times a day. This would be for a woman. Or you'd say 5 drinks in a day for men. So you could ask that as a standalone question, or you could compare it with the remaining piece of that question, which is, in the past year, how many times have you used the following? Alcohol, tobacco products, prescription drugs for non-medical reasons, and illegal drugs. So in this particular case, you don't really know if the patient is responding to the alcohol, the tobacco, or illegal or prescription drugs. So, in this case, it does help you glean some information and how to proceed. The patient could respond to each one of those saying, well, yes, I drink, 5 or more drinks in a day. I do smoke. I don't use any illegal drugs. So you may have some conversation with that patient very briefly that would help you to determine which screening tools, full screening tools, you would choose to use. And there are a number of screening tools out there that you could follow either of these pre-screening tools with. And we'll talk about alcohol screening tools first. And the one that we recommend, and for a variety of reasons I'll share with you in a minute, is the AUDIT, and its short version, the AUDIT-C. So the AUDIT-C, the C stands for consumption, and the AUDIT stands for the Alcohol Use Disorder Identification Test. And the reason why we recommend it is because it detects a full range of risks. So we go back and thinking about the drinker's pyramid, and we see there's a risk continuum in the population. We would want to be able to assess that range of risk so that we can match the level of intervention with the level of risk. And that's what the audit allows us to do. It lets us look at consumption, hazardous levels of consumption above those safe drinking guidelines. It looks at harmful use and symptoms or evidence that there's probable alcohol dependence. And notice I'm not saying diagnostic or meets criteria, but it's detecting those underlying risk events that we would want to pick up on if we're doing routine screening. So this is a very brief screening tool, and it has 10 items if you use it in full. And if you wanted to use the consumption screener alone, the AUDIT-C, it has only 3 items. So in fact, you have the opportunity, you could use the AUDIT-C as your pre-screen tool. So instead of using the 1-item alcohol screener that I mentioned a minute ago, you could use the AUDIT-C as your pre-screening tool. And then if warranted, then the patient would receive fuller screening either immediately or at some point in that next phase of where that patient is in the flow. So you have a couple of options for your pre-screeners. Now, we talk about the audit having a full range of risk. If you use the full 10 items, it will give you that rich information. It's different in compared to some of the other validated tools that are being used routinely out there now. For example, the CAGE. Now, the CAGE is it's really terrific at detecting alcohol dependence. So that risk continuum, that high risk, the folks that were at the top of that pyramid, does a really good job of identifying people up in that range. But what it doesn't do is it doesn't give you a sense of people who are below that range, who are drinking in unhealthy, risky ways, maybe experiencing some consequences, but not to an extent where they may fall in the high-risk category. So this is really a tool that is very good at identifying the high-risk patients. So if you're really only interested in high-risk patients, then it's a good selection. But I would argue that the audit would be superior because it has a full range of risk. And in SBIRT, we really want to identify people in the moderate risk range too. Because in SBIRT, everybody gets some level of intervention. So we really need a tool that will give us the information so we can really match that level of intervention to level of risk. So I would say that in many folks that I work with who are currently using the CAGE and really want to implement a broader SBIRT program, they're considering moving from the CAGE to the audit because it gives them everything the CAGE offers them plus more. And so that's a factor that you'll want to think about and consider in your own setting. Regardless of whatever tool that you decide to use, there's a really nice tool that we call the standard drink chart, and you could simply make color copies of your handouts today. You could use that as a handout that you have put right out on your desk. They're on the NIAAA website. They have a really nice image that you can use. You can print that out, or if you're doing things on computer, you could use the standard drink chart image to help have a conversation with a patient about what you mean by the standard drink. So I would encourage you to have available to your practitioner, to the patient. You could use, just thinking of the Rethinking Drinking booklet. It has a nice color brochure that you could have with you to show the patient what you mean by a standard drink. So when you're asking about alcohol consumption, quantity and frequency, whatever tool you're going to use, we want to make sure the patient understands what you mean by a standard drink, because people have very different ideas about what a drink is. So if someone is drinking a Cosmopolitan, for example, it can be difficult for them to know that that may be 2.5 standard drinks, or they're having a vodka tonic and they have they put 2 jiggers of vodka in their cocktail. This is going to help them to begin to calculate what their consumption is. How many drinks are they drinking, which helps to give your, when you administer the screening tool, for you to get more accurate results. So an example of what you might say, so you ask permission to ask questions about alcohol use, and you'd say, before I ask you about your alcohol use, I'd like to give you a sense of what I mean by a standard drink. So on this chart, it gives you examples of what a standard drink is. So what I mean by a standard drink is a 12-ounce can of beer, a 5-ounce glass of table wine, a little more than a half a cup, and 1.5-ounce jigger of vodka, gin, or whiskey. Most people can identify with those, and they can kind of visualize those. If someone says to you, well, I don't drink any of those, I drink brandy, you could say, well, what I mean by a standard drink of brandy is a single jigger, 1.5 ounces. And once they've had a chance to look at it, then I would ask them permission. Would you mind if I begin asking you some questions about your alcohol use? So this helps us all to be on the same page by what is it that we mean. If you don't know how many drinks they're having because they have a mixed drink, for example, or they say, I usually have a bottle of wine on Saturday night. Here's another chart that will just give you some examples of other things, other responses that you might hear from patients so that you can quickly calculate so that a bottle of wine would be 5 standard drinks, or a 40 would be 3.3 standard drinks. Now, if they drink a lot of fancy drinks, like the mojitos and the cosmopolitans or Long Island iced teas, one of the really nice tool online and NIAAA's Rethinking Drinking website, they have a cocktail calculator which will actually allow the patient or you to calculate how many drinks, standard drinks would be in that drink. So that's just a couple of tools that you can use so that we know when we get to scoring those quantity and frequency questions that are part of the Audit-C, the consumption items, that we're getting as an accurate screen as we can. And here are some of the other reasons. So I mentioned why we're talking a lot about the audit, but there are some other reasons that you should be aware of too. So not only does it get at quantity and frequency and risk above the recommended guidelines, but it also it's reliable, it's in the public domain, it's developed by the World Health Organization. I think it's now in 20+ languages. It can be used to monitor change over time, so you could administer the Audit-C at multiple time points, getting a sense of change in consumption over time. You could administer the audit if someone's coming in annually. You could re-administer the audit annually at physicals, for example. And there are many different ways that you can administer it that we've talked about, and it fits with other screeners. You can embed it in with other screeners around depression, drug use, and so forth. And so, and it's free, which is also very good. So free tools in the public domain that are well validated is some of the core reasons why we recommend it. And it's very brief and easy to administer. So I've been able to, in some of the studies that we've worked on, we have seen less than 30 seconds for the Audit-C, and in many cases under a minute for the full audit. And I guess it would certainly range in different settings, but it's very, very brief. So I mentioned that the audit can be used with the DAST, the Drug Abuse Screening Test, the NIAAA single-item drug screens, or the ASSIST tool, which Lee will be talking about in a little bit. And what's also very nice is that it fits well with the patient health questionnaire, the PHQ-2, which is the pre-screener for depression, and the PHQ-9, which is the full screen for depression. So if you're already using some of these tools or you want to, you can integrate them into your clinical intake process together. And they don't necessarily duplicate, but they do complement, which is what we want to do. So the NIAAA single item alcohol use, this is another screening tool that you can use as a standalone tool, or you could use it prior to the audit. So you could, here's the item that is recommended by NIAAA specific to alcohol use. So how many times in the past year have you had X or more drinks in a day? That's 5 for men, or you would use 4 for women. And this is really looking at, it does identify unhealthy alcohol use and binge drinking. So it's looking at more of a segment of the population drinking above those NIAAA cutoffs. So it's not getting at the full risk continuum, but it provides a lot of very valuable information about the binge drinking and heavy drinking. And it's possible that individuals drinking in this range who screen positive may have patterns of drinking that are like this. You could use this again with the audit, or you could use it as a standalone tool, but it's getting at different things. So the Audit-C, and some of the sites that I've worked with, they've used that one item, NIAAA single item, combined with the Audit-C, so they can get more around consumption, not just above a cutoff. And let me show you what those items are. So the first question is, how often do you have a drink containing alcohol? The second question is, how many drinks containing alcohol do you have on a typical day of drinking? And how often do you have 5, that's for men under the age 65, or 4, that's for women, older adults. So how often do you have 5 or 4 or more drinks on one occasion? So the Audit-C actually, as you can see, item 3 does actually match the single item NIAAA item. So I'm not sure that you would really need to have both of those, though I've seen it done. For efficiency, I think that you could just move to the Audit-C, and it gets you everything that item does and a bit more. And in the way that you administer this, you can actually read the response options to the patient and have them pick one. You can have it in paper and pencil, and they could read it and point to one. Or you could simply offer the question prompt and have them openly respond, and then you could circle the answer yourself. So if you have it, say, on your clipboard or something in front of you, but they're not seeing it, you could just try to match their open response to what you have in front of you. So to give you a little bit of a pointer on some of the things that have come up in administering it that way is that, for example, in question 2, how many drinks containing alcohol do you have on a typical day of drinking? Folks might say, oh, 6 or 7, or about a 6-pack. We would just encourage you to reflect back to get an accurate screen and say, well, is it more like 5 or 6, or more like 7 to 9? And so once you have the responses, you can match the response up to the points ranging from 0 to 4, and you would put those points in the right-hand column, and you would total up what the score is for those first 3 items. And so a positive screen on the Audit-C is 4 for men and 3 for women and men over age 65. So you could stop there and use that as your tool, and that would help you determine whether they're screening at risk or not. But we would encourage you to, if someone screens positive, to administer the remaining 7 items, because it provides you more information and helps to place them along that risk continuum we were talking about. The next 3 items ask about, look at capturing dependence symptoms in the last year. So how often during the last year have you found that you were not able to stop drinking once you started? How often during the last year have you failed to do what was normally expected of you because of drinking? How often during the last year have you needed a first drink in the morning to get yourself going after a heavy drinking session? So again, the response could be open. You could circle the response, match it to the points, put the points in the right-hand side, and then you would move on to the remaining 4 questions that are going to now capture harmful use. So how often during the last year have you had a feeling of guilt or remorse after drinking? How often during the last year have you been able to remember what happened the night before? This is getting at the blackouts. Have you or someone else been injured because of your drinking? Has a relative, friend, doctor, other healthcare worker been concerned about your drinking and suggested you cut down? So in your handouts that we've provided today, they're all uploaded, and Missy has provided a link to those handouts. You'll actually see a copy of the audit that has all of these questions there for you, and even as you're training or you're doing it, or if you want to use it as an interview tool where you're not sharing with the patient, you'll see that it prompts you on how to administer, how to open the conversation, in terms of giving them directions about how to respond to the questions. It will prompt you on how to score it. It even gives you a little cutoff points to help you know whether to proceed. And then at the bottom of your handout, it will provide the scoring guidelines, so how to score it for both the AUDIT-C and for the full audit. In addition, we've also provided the audit in Spanish. I also, if you are interested, have it in French, Chinese, and Japanese, and I think another language. And we've also in your handout provided you a copy with the standard drink chart, which you certainly could use with your patient. And in the handout, we've also provided some information on you about what those questions break down and what domains they're really assessing around risk. We talked about the hazardous use, the dependent symptoms, and the harmful alcohol use. So if you really want to drill down and look at, well, what are these questions looking at compared to the questions that you're currently using, that will give you a good sense of what is yours picking up on and what is the audit, and help you determine whether you want to stick to what you have or do you want to consider switching. And then the last page of your handout, we've provided you with some interpretation guidelines for the audit in terms of how to interpret the score and the risk ranges. And we've given you a couple of options and how to do that. The World Health Organization offers interpretation in terms of the zones, and that the zones would be like Zone 1 is a score of 0 to 7, Zone 2 is 8 to 15, Zone 3 is a score of 16 to 19, Zone 4 is 20 to 40, and as you go up the zones, you're talking about increasing in level of risk. One of the other protocols that we have in interpreting the audit that we're using in some of the settings that I'm working in is where it's just divided into 3 levels, low, moderate, and high risk. So the low level is a score of 0 to 7 on the audit. A moderate level of risk is a score of 8 to 19. And then the high level of risk is a score of 20 to 40. So the only difference is that we've collapsed the 2 middle zones, Zone 2 and 3, because when we asked practitioners, what would you do different with those different patient populations in that moderate risk range, most of them said, I would provide a brief intervention to anyone who's at risk in that 8 to 19, that moderate risk range. And so it was easier for practitioners to condense it and to use that protocol. So we'll be talking in Part 2 more about that protocol and what the elements of the intervention are that go into that protocol. And then the last thing I'd like to say about the scoring of the audit is that it's good to keep in mind that your clinical judgment is going to be key, because someone who's a 10 versus an 11 or a 19 versus a 20 or 21, they're on the edge of those different cutoffs. You know that the patient is complex and has multiple things going on, health concerns, emotional concerns. There may be family concerns, work concerns. People are complex and have complex issues, and you're going to be privy to a lot of information about this patient, and you have to use your clinical judgment. If someone is falling in a moderate risk range, rather, but really you feel need referral to treatment, that's a clinical judgment and something you would want to listen to. And so, these are guidelines to help you make those assessments about how much further additional resources are needed. So now we're going to move over to screening and talking about screening tools for adolescents. And you have a handout, and there are a couple of things that we've provided you. One is a copy of the CRAFFT tool, C-R-A-F-F-T. And then also we've uploaded the manual for the CRAFFT. So for those of you who are working with adolescents and young adults and you really want to start diving into the use of this tool, there's a manual that helps you guide you into implementation and how to provide brief intervention around the levels of risk and how to introduce it. There's lots of really great information and when working with young adults, and it is different than working with adult patients and how you approach the issue. You may start with approaching screening by talking about, asking about their friends' use versus what we typically do with adults is ask them about their use. So there's a lot of great guidance in there, so I would encourage you to review that if you're interested in screening adolescents. And I will say that the CRAFFT tool is recommended by a number of organizations, including the American Academy of Pediatrics Committee on Substance Abuse. And this is a free public domain tool as well. And it's very brief. And the CRAFFT is really an acronym that really stands for the 6 screening questions that are embedded within it. So have you ridden in a car driven by someone, including yourself, who was high or had been using alcohol or drugs? The R is do you ever use alcohol or drugs to relax, to feel better about yourself or fit in? The A is do you ever use alcohol or drugs while you are by yourself or alone? The F is do you ever forget things you did while using alcohol or drugs? The second F is do your family or friends ever tell you that you should cut down on your drinking or drug use? And the T is have you ever gotten into trouble while you were using alcohol or drugs? So it's asking age-appropriate questions about risky alcohol and drug use within the same item. So it has the benefit that it's very concise and it's asking about both, but you may not be able to determine whether the trouble they experienced, for example, was due to alcohol specifically or drugs. But many would argue that either one is problematic and they're at risk and would need a level of intervention and maybe additional treatment or care and so forth. So it's a very nice tool and can be easily integrated. To score it, a response to 2 of the items is yes, is regarded as a positive screen, and you would then want to consider further assessment. And so even if we can't tease out at that screening level, are those things being experienced to alcohol or drugs? Once they are referred to further assessment, that's where you would expect that at that level of care that they would be teasing that piece out. Certainly at further assessment points, they would be determining whether there's a need for referral to treatment, whether brief intervention would be appropriate at that level of risk. And so the CRAFFT guide, the manual, certainly can help you with determining those levels of care and getting the patients that are screening at high risk into the right levels of treatment based on the responses in the scoring. The other adolescent screener that I'll point you to, and that we're really hoping to have a webinar on this not in September, but in the coming months, we hope to have a webinar devoted specifically to working with adolescents. We could talk more about the CRAFFT and the use of it and the brief intervention, but also to bring forth a lot of the great guidance that's come out in the NIAAA Alcohol Screening and Brief Intervention for Youth Practitioner Guide. And this really recommends two age-specific screening items, and they're matched at the level of their school age, elementary, middle, and high school. And one question is about the friends drinking, and the other is about their personal drinking. And how they approach it for an elementary student and how they ask about these things would be different than how they might approach it asking the question to a high school student. So we won't go into a lot of in-depth information here, but I want to point you to it because I think it's a terrific resource, and I've provided you a link, and it really breaks down into the flow process if a child is in a certain age level in elementary school, what order you would introduce the screening, those two items in, the scripting of how you would actually introduce it, and what it means to be at risk if someone says that their friends are drinking. You know, if a friend, if an elementary child's friends are drinking, that's a different level of risk. That's an immediately a high-risk category versus if you're in high school and their friends are drinking. It doesn't mean that child is automatically moved into a high-risk category. So it really helps discern and takes into account the age of the child. So I really encourage you to consider that if you're working with these populations. So now let's talk about some of the combination, the joint tools that look at both alcohol dependence and drug use screening tools. The CAGE, we mentioned the CAGE earlier, and the CAGE we talked about is really looking at dependence, but there's another version of the CAGE called the CAGE AID, which picks up on both alcohol and drug use. So I've shown you here just the CAGE so you can see what the differences are. You can see it's talking about cutting down on drinking. Do you get annoyed when people talk about your drinking? Do you feel guilty about your drinking? Have you ever had an eye opener? So the CAGE is an acronym for cut down, annoyed, guilty, and eye opener. But you notice they're all talking about drinking. And when you're using this, two positive responses are considered a positive screen for ever being dependent or potential alcohol problem. You have the opportunity to use this alone, or you could use it the other version, which is the CAGE AID. And you'll see that it combines the CAGE items, cut down, annoyed, guilty, and eye opener. But you'll see at the very tail end of each item, it says cut down on your drinking or drug use, or annoyed you by criticizing you about your drinking or drug use. Have you felt bad or guilty about your drinking or drug use? And have you had a drink or used drugs first things in the morning to steady your nerves or get rid of a hangover? So if you're in this particular, with this particular tool, one positive response, as opposed to just using the CAGE focused on alcohol, in the CAGE AID, one positive response indicates a possible problem, and two positive responses indicates a probable problem. So this would warrant further assessment, referral to someone for more in-depth assessment of both alcohol and drug use. So let's move to drug use screening tools. So we know that tens of millions of people have used prescription drugs for non-medical reasons, and opioid pain medication misuse is really a growing public health concern, and I'm sure something that here in your setting you've seen. It's with SBIRT around drug use being promising, we have a real opportunity to integrate validated, brief drug use screening tools the way we have been doing much longer around alcohol and tobacco. We have a really great opportunity and many different options available to you, both single items as well as multiple items, but all brief, where we can integrate them seamlessly like we are around alcohol. And what we also, want to keep in mind is that, drug use is not necessarily a common presenting problem in many settings. And so even alcohol being a sensitive topic, and that's not the presenting problem predominantly, but it's a sensitive topic. And so, now we're introducing a topic that may be even more sensitive. And so we would just, go back to our key successes of being respectful and non-judgmental, and using that non-confrontational approach. All of those things are important in delivering the screening questions around drug use as well. And people may feel a little uncomfortable, just like you may feel uncomfortable. So we would encourage you to practice delivering these as well, so that the more comfortable you are, the more likely they are to respond to you. and to use screeners that really look at both illicit use and prescription drug misuse. And some of the older tools had traditionally focused on illicit use. But given the growing concern, we would be better positioned to be screening for both, and both can be done very quickly. So here's the single-item drug use screen by NIAAA. How many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? So here they're responding to one or the other. We don't know which, but either one is risky and problematic. And so a response of one or more is a positive screen, and that would warrant brief intervention and or referral for further assessment and a handoff to someone maybe in the hospital setting. Could be a health educator, could be a caseworker, social worker. It could be a referral source that you're connected to in the community. But that would be enough to warrant some further assessment. The DAST screener is another publicly available tool. It has many different versions. Over the years, I think the most common one that people were aware of is the DAST 28, so it's 28 items. And we have a copy of that. That's really something that you want to use. But I'm proposing here that the brief version, which seems to perform as well as the DAST 28, is the DAST 10. And the DAST 10 is assessing a degree of problems related to drug use in the past year. So again, we're talking about more of a continuum of problems, a degree of problems, continuum of risk. As we talked about with the audit, has a continuum. So it's the same thing here. And it's also picking up on drug use broadly as prescribed or over the counter in excess of directions or as prescribed, and any non-medical use. So you can implement the DAST screener the same way as you can the audit. You could take the first item and use it as a pre-screen to determine whether you want to ask the remaining questions of the DAST. And so you can simply ask this question: in the past 12 months, have you used drugs other than those required for medical reasons? If the answer is yes, that's considered a positive screen. And then you would administer the remaining 9 items, which comprise the full DAST 10. If no, then you might move on to the next set of screening questions that you're asking. And here are the items in the DAST 10, and we have provided in your handouts copies of the DAST 10 and a way to interpret the DAST 10. In fact, a very nice a nice copy is provided to you, compliments of the Colorado SBIRT, and Lee Fisher, who will be talking about the assist soon. She is part of Colorado SBIRT, and this is the very nice version that they have made available to us. And it has all the 10 items on it, as well as on the back it has a way of scoring it for you. So it provides you not only how to score it, but also how to interpret it. So if you have a copy of that handout, it's showing what's on your screen now, but you can certainly take a look at it. And that could be used if you're administering it verbally on a clipboard. You may actually, you could make multiple copies of this and have one for each file, or it may be something you want to integrate into your electronic records. But the Colorado SBIRT site offers a number of resources like this that you can download from their website for free to help you implement and interpret these screening tools. So you'll see that the DAST 10 is looking at use in the past 12 months. Like the audit, we're looking at last year use. And the first question is, have you used drugs other than those required for medical reasons? So that was our earlier pre-screen. So assuming they said yes, we moved on to item 2. Do you use more than one drug at a time? Third question is, are you always able to stop using drugs when you want to? The fourth item is, have you had blackouts or flashbacks as a result of drug use? The fifth item is, do you ever feel bad or guilty about your drug use? Item 6, does your spouse or parents ever complain about your involvement with drugs? Have you neglected your family because of your use of drugs? Have you engaged in illegal activities in order to obtain drugs? Have you ever experienced withdrawal symptoms, felt sick when you stopped taking drugs? And have you had medical problems as a result of your drug use? Memory loss, hepatitis, convulsions, bleeding, and so forth. So all of these are yes, no response options, and you can simply administer it and circle the one, and you would count up the responses to the yeses and to the no's. And what I will point out is you have to make sure you know which version you're using, because there are a couple of versions of the DAST out there where you score 1 point for each question, which is a yes, except for question 3. So your handout, this is the one that we're using that I'm talking about right now, that receives a no point. So that's because it's reversed. It's the way it's phrased is that it's phrased in the opposite direction. So you just have to make sure you take a look at item 3, because I've seen versions out there that are worded slightly different, and that would affect your score. So if you have any questions about a version you're using, feel free to email one of us, and we can take a look just to make sure you're being able to score it correctly, because that helps to determine how you interpret the screening tool. So here's the interpretation. So if you score it and the yeses are 0, no problems reported, and there's no suggested action. If it's a 1 to 2, it's a low level of degree of problems related to drug abuse. If it's a 3 to 5, it's a moderate level degree of problems related to drug use. 6 to 8 is considered substantial, and 9 to 10 is considered severe. And I've also seen other versions, just so that you know, in case you're using one of these or you're out there looking for copies in your own research, there are versions that will stop at 6 to 8, and they won't even show a score of 9 to 10, because what they did is they just collapsed it and said anything above a 6 is substantial and it's high risk, and they would need intensive assessment, referral to treatment. So they are the same tool, and it's essentially the same interpretation. It's just this one breaks it down a little bit finer for you. And then the nice thing about this tool is, like the audit, it gives you the recommended level of action, a suggested action, or level of brief intervention that matches that full risk continuum, that range of risk, that level of risk. And for those of you who use ASAM criteria, this is a terrific resource. It helps break down, if you're going to use the DAST-10, it gives you the different scores that we just covered, the low through the severe. If you decide you want to use the DAST-20, it also provides you with that. Or if you're currently using the DAST-20 and you don't want to change, this could be helpful to you too. And it gives you some suggestions around the action, around whether monitoring them, providing the brief intervention counseling, and so forth. But what's really nice about this is that it gives you the ASAM, it matches with the ASAM placement criteria, which is in many settings, and depending on the kind of practitioner that you are, this is very important. And you have to report where someone is in matching with ASAM criteria. So I thought this was a really nice resource. I want to make sure I included that for you. And if it's not really relevant to what you're doing, but you're going to be working with licensed clinical social workers or counselors or other addiction professionals, nurses, and so forth, this may be of value to them, so you may want to pass that down. Okay, so I am going to hand it over now to Lee. I want to thank everyone for joining and up to this point, and I'm going to have Lee now introduce herself and talk to you about the ASSIST screen.
Thank you, Tracy. Again, my name is Lee Fisher, and I'm the program manager for the SBIRT Colorado initiative, We are SAMHSA funded, and the goal of our work is to integrate screening and brief intervention for tobacco, alcohol, and drugs into healthcare settings across the state of Colorado. So over the course of the last 6 years now, we've worked with hospitals, primary care clinics, community health centers, FQHCs, HIV treatment and prevention programs to integrate routine screening for substance use and to provide effective evidence-based brief interventions based off of screening results. I'm happy to have the opportunity to share with you all our experience using the ASSIST screening tool. This is the tool that we most commonly promote and we most commonly see utilized in our healthcare settings in Colorado. The reason that we promote the use of the ASSIST tool is because it assesses for tobacco, alcohol, and an entire list of illicit drugs. It also assesses for the misuse of prescription medications. So we just find it's a very comprehensive and useful tool for really good at getting good, accurate risk levels. So with that being said, I'll share with you a little bit more about the actual screener. The ASSIST stands for the Alcohol, Smoking, and Substance Involvement Screening Test. The ASSIST was developed by the World Health Organization a little over, I would say, 12 years ago. It was the late 90s when all of the validity testing was completed. And there's been different stages in terms, or different phases in terms of testing the ASSIST and getting it out there into practice. The ASSIST is validated in multiple languages, and it was tested in multiple different countries. And so we also appreciate that about this tool, that we can use it to screen diverse populations around the state, and we can trust that it's been validated for those different populations. It is an 8-item questionnaire, and it's intended to be completed in about 5 to 10 minutes. And of course, the length of time spent administering the tool depends on the number of substances the patient reports using. And I use the word patient, but we have seen community-based organizations and schools utilize this tool. And so it doesn't necessarily need to be within the context of a healthcare setting, but I would say that it was intended in its original development to be used in primary care. The ASSIST is meant to be verbally administered, so it is a paper and pencil, it isn't valid as a paper and pencil screening yet. However, that has been part of the work of phase 4 of ASSIST testing. So we expect to see soon from the World Health Organization a version of the ASSIST that can be self-administered. So you could actually take the form, hand it to a patient, they could then fill it out themselves. But at this point, it is intended to be verbally administered and scored by a health professional. The other piece of phase 4 of ASSIST testing I wanted to highlight is that they're working on a condensed version of the screening. So I mentioned right now it's an 8-item screener. We expect to see an even shorter screener coming down the pike sometime soon. So that might be something to stay tuned for. The final piece about this, before I dive into more details about the actual questions, is that the ASSIST is really intended to be linked into a brief intervention. And that's another piece about it that we really have appreciated in Colorado, is that it flows, the information you gather through the ASSIST and all the supplements to the ASSIST flows very nicely into a brief intervention. It just becomes one continuous process. So what exactly does the assist do? It screens for risky substance use, and then it scores the results of each particular substance. And it puts the scoring into a risk-related category. So you could be low risk, moderate to high, or high risk for each substance. So you could be low risk for cannabis and high risk for tobacco. So you will have different scoring breakouts for each specific substance. And it really does give you a starting point to have an effective intervention with the patient, because you will have detailed information about their use of each substance that they have been using. It really looks at lifetime use, and then it narrows it down into substances patients report using within the last 3 months. And so most of the questions are really focused around those past, looking at your use within the last 3 months. But there are a couple lifetime use questions in the ASSIST tool. It helps you detect any sort of problem related to their use of those particular substances. So social, legal, financial, health-related problems. It really helps you kind of delve into all of those different areas with your patient. It also assesses for dependence. Again, it is a screener. It's not intended to be a diagnostic tool, but it will assess for dependence, and it assesses for injection drug use. You will have the opportunity to look through your handouts and download the ASSIST manual. We've listed the full ASSIST manual and then also a more condensed version, but I encourage you to get comfortable with the full ASSIST manual. It can also be found on the World Health Organization website because it really provides more detailed information about the scoring, but it also provides a detailed introduction to the ASSIST. So an actual introduction you can use before asking the questions of your patient. So it talks about the purpose of the screening. It lists all of the substances. So you would be speaking with your patient and you would say, I'm going to be asking you about these particular substances, tobacco, alcohol, cannabis, and so on. In introducing the ASSIST to your patient, you would also want to provide to them the response card, and the response card is part of the ASSIST manual that you can download. The response card then gives the patient an idea of what the different categories are and how they should be responding to the questions that you're asking. So you could introduce, when you're introducing the ASSIST, you would introduce how to use the response card, and it's something the patient can just hold and follow along with. And then explain in your introduction that you'll be asking some questions about use within the last 3 months and then use over the course of their lifetime. And then the other key part about the introduction to the ASSIST and when you're talking with your patient is to really clarify what you mean when you're referring to prescription drugs. That when you're asking the ASSIST questions, you're not trying to collect information on medications they're using as prescribed. But what you are trying to ask about are prescriptions that maybe they're using outside of the way they were intended. Maybe they're using a prescription that's expired. Maybe they're borrowing somebody else's prescriptions. So it gives you an opportunity at the onset to just clarify to the patient what it is about prescriptions that you're really asking about so that they know how to respond to those questions appropriately. So this is a look at the substances that are covered in the ASSIST. And I don't know if you can see the top there says tobacco products. So you would say to your patient, I'm going to be asking you about these various products, or these various substances. The first is tobacco products. The second is alcoholic beverages. The third is marijuana. The fourth is cocaine, and then on. So you can see that the assist tool includes quite a variety, pretty much the full scope of substances, and then there's an other category. So we always encourage healthcare providers in Colorado, if the patient says that they're using a specific drug that you're not familiar with and you're not sure which category that it falls into, to just list it as an other. So the response card in the assist cues the patient to the different categories for each specific question. And I'm going to take the opportunity to list off the questions for you so you have a sense of what they are. The first question is, in your life, which of the following substances have you ever used? And so that is where you would go down this list to the patient. And you might have a little show card or a flyer that you can hand the patient, and they can follow along and see all of those substances and the different names for each of them. So that was question 1, lifetime use. Question 2 then narrows it down into the last use within the last 3 months. So question 2 reads, in the past 3 months, how often has your use of the following, the substances you mentioned in question, how often have you used the substances you mentioned in question 1? Excuse me for that. So again, it is, in the past 3 months, how often have you used the substances you mentioned in question 1? So you cross out the substances they said they've never used in their lifetime, and you just kind of focus in on those that, that they've ever used, and you're looking now at their use within the last 3 months specifically. And so the response categories for question 2 are never, once or twice, monthly, weekly, daily, or almost daily. If the patient says never to all of the substances in question 2, then you would skip ahead to question 6. So there are some nice skip patterns built in throughout that make this go pretty quickly once you're familiar with it. However, if the patient reports once or twice, monthly, weekly, or daily on anything in question 2, then you would proceed to question 3. Question 3 is, during the past 3 months, how often has your use, how often have you had a strong desire or urge to use? And then you would list the substances they reported in question 2. So this is getting at strong desire or urge to use within the last 3 months. And again, the responses are the same as number 2, never, once or twice, monthly, weekly, or daily. Question 4, during the past 3 months, how often has your use of the substances listed in question 2 led to health, social, legal, or financial problems? So again, you're looking at those that they've used within the last 3 months, and you're assessing for health, social, legal, or financial problems. Question 5, during the past 3 months, how often have you failed to do what was normally expected of you because of your use of the substances reported in question 2? Okay, so on the screen in front of you, you can see the responses to those questions 2 through 5. On question 6, there's a bit of a change in the response options. So question 6 looks back at lifetime use. So you're no longer looking just within substances used within the last 3 months. You're really going back to question 1 and assessing for all of the substances they ever reported using in their lifetime. Question 6 reads, has a friend or relative or anyone else ever expressed concern about your use of, and then you would list all the substances they reported from question 1. And the response categories are no, never, yes, but not in the past 3 months, or yes, in the last 3 months, or in the past 3 months. So you would prompt the patient to respond accordingly. Question 7 then is, have you ever tried and failed to control, cut down, or stop using the substances mentioned in question 1? So again, looking at lifetime use, have you ever failed or tried and failed to control, cut down, or stop using? And then the final question is, have you ever used any drug by injection? So the next step, obviously, is putting together the score of the assist. So assuming you've moved through the 8 questions, and again, it gets very quick once you're familiar with the tool, you will then add up the score for each particular substance. Each of the responses have a numerical score to go along with it. And so when you download the full manual, you can take a look at those numerical scores and how each question is weighted. And of course, as Tracy mentioned at the very beginning, if you have any questions when you're starting to practice this, feel free to contact me. I do want to note that questions number 1 and 8 are not included in the score. And so please keep that in mind when you're starting to work with this tool, that questions 1 and 8 do not count in the final score for each substance. So you will really be looking at questions 2 through 7, adding them together, and then you get a specific substance involvement score for each drug. There is, in the full assist manual, there is then a place where you would document the score for each of these. And then there's risk categories next to that showing how do you interpret the score? What does this really mean? This is how we score the assist in Colorado. The assist manual developed by the World Health Organization breaks it into 3 categories. So they have a low risk, a moderate risk, and a high risk category. In Colorado, we have broken it down into 4 categories. So anyone who scores a 0 to 10 on alcohol is low risk, and they receive some positive reinforcement and a bit of education, maybe about the alcohol drinking guidelines, the alcohol pyramid, that sort of education. For all other substances, including tobacco, a score of 0 to 3 is low risk. For alcohol, a score of 11 to 19 is then what we call low moderate risk. And then for all other drugs, it's that score of 4 to 19 is low moderate. And so that's the target population here. This is where you can then really use your brief intervention opportunity to provide some education about the risks due to their use and follow up on some of the information they provided in their assist. If you have a patient who scores a bit higher than that, so in the 20 to 26 range, we recommend the brief intervention as well as a referral for some brief therapy or brief treatment. So anywhere from 1 to 6 sessions of solution-focused or enhanced motivational interviewing type therapy would be most beneficial for that category. If you have a patient then who scores 27 or higher on any particular substance, that is considered the high-risk category, and so the patient is likely to be dependent. Again, it's not diagnostic, but it is likely if they are scoring that high that they could be dependent and would benefit from a referral for a full comprehensive assessment. So that's really our referral to treatment category there, a score of 27 or higher on any substance. And I talked a little bit about what these different categories mean. But I really want to, again, mention the benefits of using a validated tool such as this to identify your brief intervention category. And that group of patients who's really, starting to experience some consequences, starting to maybe have some health problems that are exacerbated by their use, and to really intervene at that time point using the brief intervention skills. The final piece to the assist that I wanted to mention is that there is a feedback report card in the full manual, and this is the take-home item for the patient. So it's a place for you to record the score for each substance and to highlight the level of risk for each substance. And then it gives you the opportunity to ask for permission of your patient to provide some feedback related to their score, which then flows right into your brief intervention. So the feedback report card has a risk continuum for each particular substance that you can show the patient. So you can show the patient that, say they have a score of, let's say 22 for tobacco, and you can show on this risk continuum what health consequences they are likely to be experiencing or at risk or at future risk of experiencing if they continue to use at that level. And so the risk continuum for tobacco at that level talks about heart disease, stroke, cancers, kidney disease. And so there's a risk continuum for each particular substance. So you can talk with your patient about their tobacco risk, and then you could go over some of the health-related consequences due to their current level of alcohol use, and so on. So if you have someone who's using tobacco, alcohol, and cocaine, you can really dive in and talk about the specific health problems that might be associated with their use of tobacco, alcohol, and cocaine. What we see in Colorado is a lot of times that information is very surprising to the patient. They don't necessarily realize that their alcohol and depression are related, and that their use of alcohol is making their depression worse. And so this part of the assist tool is really beneficial in helping your patient understand why they're being asked these questions in the context of a healthcare appointment. So again, I encourage you to take a look and practice a bit with it, because it really does help you offer effective brief interventions. So with that, I'm going to pass it over to Tracy, and then we'll have an opportunity to answer questions at the very end.
Great, thank you, Lee. That's really nice to have someone who's been using the assist, and I've been working with more hospitals who are really trying to figure out how to implement it and don't know a lot about it. And I think that provides a really nice snapshot, and we've uploaded a copy of the assist and the manual. And I imagine, Lee, there are other resources on the Colorado SBIRT website, and so we may want to have you give us a link, and we can put that up on our website to some of the protocols and things that you use in the work that you're doing. So we'll make sure we get that from you. So appreciate you sharing those tools that you're using out there. And we have, in addition to the handouts we provided today on all of the screening tools that we've discussed, we have available references and copies of more screening tools. Should you be interested, for example, we talked about the PHQ and depression screen, and I know in Colorado they screen for They pair the Assist with other screening tools out there, and if you're interested in any of the things we've talked about today or we've referenced, those tools are likely to be found in this new Learner's Guide, which has been developed with all the collaborators that we mentioned earlier to put this content together for you for this 3-part series, but there's even more information in the hard copy Learner's Guide for health professionals on screening, brief intervention, and treatment, which if you're interested in, please let me know, and we can work with you to get you a copy of that. And also, I would encourage you, if you want to reach out to either Lee and I for follow-up questions or more materials as you dive into our websites and find things, or to the guide. Certainly, here's my email address, and the slides are up and available to you as a handout, and hers isn't noted in the beginning. So thank you very much for joining us today for part 1 of this 3-part session. Here is the information for part 2 for you able to register, which is on September the 25th from 2 to 4 Eastern. And as you can see, we'll be talking about how to move from screening using these tools and the information gleaned from scoring and interpreting these tools, how to determine the level of brief intervention, how to use brief intervention protocols that actually had examples of scripting, which show you how to move the conversation from screening to brief intervention, how to deliver brief intervention, and how to use motivational interviewing strategies to hopefully move people along in that process of behavior change, or that thinking process of making a change. And we'll be providing copies of those protocols that have the scripting. Some of those are available complements of Colorado SBIRT and Lee's team. And we'll also make available to you some educational and self-management materials and point you to some resources that are out there, again, public domain, free, that you can use in your own site. And then the 3rd part on September the 27th, also from 2 to 4 Eastern, we'll be talking more about the use of referral and using motivational interviewing strategies to make referral, to facilitate a linkage, that warm handoff process, moving people through care and to that next level of care, and how to provide continuing care support or linking them with further treatment resources that can provide some of that follow-up care and continuing support and recovery support. And again, a complete list of webinars. We've had some really terrific webinars around reimbursement and coding, the business case for screening and brief intervention. All of those are done, available, and archived on our website. And we'll be having more as well through the month of September and maybe even early October. So we hope you will join us for those. So we're going to hold the line and we're going to open it up for questions and answers. So